Just a brief note about Jeffrey's background. Jeffrey received his bachelor in applied mathematics from Georgia Institute of Technology, and he was an NSF graduate research fellow from 1990 to 93. He received his PhD in industrial and systems engineering from University of Florida. And then he was actually a postdoctoral associate here in the Institute for Systems Research from 1993 to 95. Jeffrey's work is on applied research projects supported by National Science Foundation, NIST, ONR, Lockheed Martin, and a number of other organization funding agencies. His current research includes design and control of manufacturing systems and integration of product design and manufacturing system design. I would like to encourage everyone to ask questions and make this an interactive seminar series. And so with no further ado, I'd let Jeff start this.
Okay. So yeah, of course we'll do a new turn on the left. They told me the mic would work much better this month. So now I have the problem of being too loud again. How's that, Alex?
It's good for me. Is it too loud?
A little bit too loud. How about that? Better? I keep turning the volume down. Oh, okay. Okay.
Fix the mic.
How about that? Is that okay? Okay. Anyone from one? Okay.
I'll get this. Let me take a picture first.
Okay.
And then I'll do it.
Okay. Well, thank you for that introduction, Teresa. As when I first started here in ISR, it was I came with a degree in industrial engineering, industrial systems engineering. I was mostly doing work in production scheduling. That's what my dissertation was on back at the University of Florida. And here I was joining the ISR with all these great faculty doing all kinds of different types of research. And when I was first hired as a postdoc, I was working for Yannis Minis, maybe some of you remember. He's now in Greece, being happy there and successful. And in the first part of my research here, I was working mostly in production scheduling and manufacturing. And then through Yannis's influence, I got involved in product design and product development, and got into design for manufacturing. And so I was working in that area for a long time and working with my students and publishing papers and getting grants and all that fun stuff. And now I'm going to talk about public health emergencies. So there seems to be a disconnect there. But the common theme through all of that is the discipline of operations research, which is what I was learning both as an undergraduate at Tech and then as a graduate student. And I was basically working in the area of operations research the whole time. And one day, about 7 years ago or so, I got a phone call from someone at the state of Maryland. They called up and I didn't know the person. They said, "Do you know anything about queuing?" And I said, "Well, yes, I know something about queuing. I do operations research. I know a lot about queuing." They said, "Okay, good. There's some people in Montgomery County, and they need some help with queuing." And I said, "Okay." And he said, "Here's the lady's name, here's the phone number, give her a call." So I called the lady, Carol Jordan, in Montgomery County, and I explained who I was and told her I'd heard I needed some help with queuing. She said, "Oh yeah, we need some help with queuing." So we set up a meeting, and I found out, started learning about what they were doing. This was like 2003, 2004 time frame. And then we started working together, and then we had this exercise in the summer of 2004, and we did a time study and built a model, which I'll talk a little bit about today. And then they started getting some funding to put together a center to support research and development of tools to help public health people. And through our collaboration, they were able to give us some money so I could hire graduate students and build more models and write papers and do stuff. And the rest is history. And that's how I got to where I am today. And it's been a lot of fun. And what I'd like to do today is talk a little bit about that area of using operations research to plan for public health emergencies. And I'm going to put that in the context of a larger process where I'm going to be talking most of the work that we've done has been mostly in the area of planning for the response. But it's important to keep in mind that this response occurs after the processes of detecting an outbreak, such as an anthrax attack or a smallpox, or even a pandemic influenza or some other communicable disease. And then there's a variety of systems that are in place now for detecting those outbreaks. And these include the environmental monitoring systems like BioWatch and other systems that are in place. Clinical diagnosis, basically sick people going to the doctor, and the doctor says, this is unusual, I never saw this before, right? And then they let the public health people in the health department know. And syndromic surveillance, which is basically the automated monitoring of databases to keep track of how many people are going to the doctor or the emergency department or buying pharmaceuticals or whatever. And when there's a spike in that data, they can issue an alert that the health department then investigates. Well, but the next thing that occurs after the detection is the outbreak investigation. They have to figure out, was this a real outbreak, or is this just an anomaly? What is the scope of it? Is it just a few people that ate something bad at a restaurant, or were exposed to something, or is this a community-wide thing? And then they have to determine how to respond, right? Are we going to vaccinate the people at a factory, or do we need to give out medication to the entire population? So there's a big process here. And what I'd like to encourage you to do as I talk today, is I'd like to encourage you to think about how your expertise in different areas of sensors or information systems or statistics and decision theory, our operations research can be applied in these areas. It's the areas I'm going to talk about today, and some of these more general questions. There's a lot of opportunities to do research in this area, and it takes more than just people building mathematical models and developing decision support tools, which is my particular niche. Okay? So I encourage you to think about that, and I'd be happy to talk with you afterwards about that. Okay? But in my work, we've been looking mostly at planning problems. So these are the types of questions that we've been trying to answer. Okay? Given that we have a limited amount of medication, who should receive the medication? Okay, for instance. How should this medication be delivered to the points of dispensing, the places where they're going to give out the medication? Okay? What's the best layout for the pod? How should we physically lay out the facility? How many staff do we need? How much capacity do we have? How long are people going to wait in line? Okay, that's an important problem. And how can we improve the processes? And I'll talk about the screening step. Okay, and in some of these cases, it's the application of existing OR techniques and knowledge. And in other places, we've had to develop some new models and some new techniques. Okay, but I hope that this will kind of give you an overview of the types of things we're going to talk about briefly today. So the first question was, well, who should get the medication? This problem was especially important last summer. Okay, after the pandemic influenza had been noticed, had been detected and investigated, and they realized that they needed to make this vaccine so that people could get vaccinations against the pandemic flu, the novel H1N1 flu. They realized that there wasn't going to be enough of the medication, enough vaccine available for everyone at the beginning of the fall. You may remember that controversy or that problem. So the federal government convened a commission, and back in July, they identified the target groups that should have received that medication. So there were high priority groups like healthcare workers and pregnant women and children and young adults, and people who had chronic illnesses or people who worked with infants. Those were like the high priority groups. And then the next priority group was basically healthy adults between 25 and 64. And then the third tier was basically healthy adults 65 and older. Okay? Well, I'm a health department, and I know, or I can estimate how many people I have in each of those target groups, and I'm told by the state or by the manufacturer that I'm going to have so many thousands of doses of vaccine. I want to know who's going to get the medication. How far down that list am I going to be able to get? Am I going to be able to get all the high priority groups? If so, how far into the second tier, or can I get down to the third tier? And I need that. I need to know that so I can figure out how to distribute the medication. Whom should I invite to the clinics? With whom do I need to communicate? So last summer, we were able to develop the vaccine allocation model, which was a fairly simple mathematical model to go down, basically look at those target groups and figure out which groups to get the medication. And we implemented it in an Excel spreadsheet for easy use by the public health officials. So the vaccine allocation model takes in some basic information about how many vaccines do you have, how many people do you have in each of the target groups, and it says, okay, so many people in this target group get the vaccine, and then you move on to the next target group. So in this diagram, see, here's the first target group, or the first tier of target groups. In this particular example, everybody in that group gets medication, and about half the people in the second tier get medication, and nobody in the third tier gets medication, because you just don't have enough medication, right? Okay. So we were able to do that and develop a very flexible model and get that out very quickly. So that was a case where we could develop a model very quickly and disseminate it very quickly through our collaboration with the public health departments. Okay. The next next issue I want to talk about are points of dispensing. The purpose of points of dispensing is to give vaccinations or dispense medication to a large number of people in a short period of time in a public health emergency, where you're not able to use the existing healthcare system. You can't depend upon the hospitals are crowded. There's not enough time to give this to the primary care physicians or through the pharmacies, or those types of clinics. Okay? So the public health people have spent a lot of time in the last 10 years trying to figure out how they're going to do this, because there's many scenarios in which they would need to give out medication in a short period of time: smallpox, anthrax, and even pandemic flu. Okay, now. One comment about the pandemic flu that is going around right now. We've been very fortunate that the severity of that flu has been moderate, right? When you look at the death rates and hospitalization rates from that flu, it's very low, not nearly as high as some of the really awful flus that we've had in the past. And the good thing, the silver lining in that, is that it's given the public health people a great opportunity to practice and improve their plans for mass vaccination. They've taken those plans that they had for smallpox or whatever, and they've used them to set up pods. And they've seen what worked and what didn't work. Okay? And then now they've been able to revise those plans. For instance, the University of Maryland last fall had a flu shot clinic. Now it turns out they were giving out the seasonal flu shot, not the H1N1. But they were basically exercising their plan for mass vaccination. And we got to work with them a little bit, and I'll talk a little bit more about that later in the talk. But there's a lot of different scenarios where pods are important. Now, one of the issues with pods is you have to give out all this medication in a short period of time. Well, the states and the counties, they don't actually have this medication, sitting in the warehouse at the local health department. The federal government and various manufacturers stockpile this medication. So if they need to give out the medication, the state or whoever calls up the federal government and says, hey, we need antibiotics to treat people for anthrax, send them to us. So then the government sends it. And there's kind of like a supply chain. Okay? The medication has to go from the stockpile. There's actually multiple stockpiles at the federal level, and like I said, the vendors have to also send the medication. Then there's like a state level depot, and then from the depot, the state or whoever ships the medication to all the different pods, because there'll be multiple pods within a jurisdiction. Okay, so for instance, at Montgomery County, some of their plans call for setting up pods at all the elementary schools, and there's like over 100 elementary schools. Okay, so figuring out how to get this medication to all these pods in a short period of time is a very difficult operational problem. Okay, very similar to the vehicle routing problem. Okay. One of the things that makes it different from the vehicle routing problem, if you're familiar with that, is that we're more concerned about time than we are concerned about cost. We have a fixed number of trucks or drivers or medication, but we want to get it to the pods as quickly as possible. Okay? That's the key. So for instance, just as an example, here's a map of Montgomery County. The medication might come to a depot in the middle of the county, and then it's got to be sent out around these trucks, all to all the different schools throughout the county. Okay, so each of these colored little jagged lines represents a truck route. And of course, Montgomery County is a very large county, of course, nearly 1 million people, and it has areas that are nearly urban, so lots of suburban areas, and then also areas up county that are very rural. So it's quite a mix of different settings. Well, if we look at the distribution of medication, and we look at one pod, and we look at the inventory of that pod, then we can draw a graph that looks like this. The horizontal axis on this graph is time, from the time that the medication arrives at the depot. Okay? And this blue line over here represents the dispensing, or how quick or how much medication the pod is going to give out. So there's some delay between the time the medication arrives at the depot and the time that the pod starts giving out medication. But once it starts giving out medication, it's pretty much going to continually give out medication. And that the rate at which it gives out the medication is basically limited by the staffing available. How many nurses do we have to give the medication or give the shots? Well, if we look at the deliveries, which are shown here in this red stair-step kind of figure or line, the deliveries occur in discrete batches because they don't get all the medication all at once. They get some of it initially, and then they get more deliveries over time. And so the trucks that are sending out the medication, they send out some medication, they come back to the depot, they reload, they go back out, deliver more, they reload, they go out again, and reload. And so they do this in different waves, we call it. So that's why we have this stair step, because this represents the first delivery, then the second delivery, third delivery, so on and so forth. Yes?
This looks like every 6 hours. I mean, that's surprising to me. Is that a realistic number?
6 hours is a realistic number for them to get the medication from the national stockpile and the different vendors they're going to provide. But in any particular scenario, it could vary. It could be every 3 hours, or every 4 hours, or every 8 hours. I mean, they have to communicate. So one of the but 6 hours is a reasonable number based on what they told us. Okay. The point is, yes, I'm sorry.
Is this based on the actual data or based on the model of
This is our model of the problem, for populating the model at this point, we have used data that they provided to us as estimates of what they can do, okay, of what was going to happen. Our purpose in doing this research is to develop models which we're going to then translate or implement as planning models, which we're then going to hand over to the public health people, you see. So that they, when in the particular situation that they find themselves in, they can put those numbers in. Well, there's two things. They can do it ahead of time, or they can do it in actual situation. But they can put in reasonable numbers for what they expect to happen, and then figure out how they're going to deal with that. Okay? So this is a planning model, right?
is it deterministic?
This model is deterministic. Yes, I'll talk about the fact that we need to use stochastic in the future. But for planning purposes, we can build a deterministic model. Okay? Because in the planning problem, getting ahead of myself, but the planning problem is basically to figure out, given a certain number of trucks, what routes are the trucks going to take? Like which sites should which trucks visit? Okay, so it's a routing problem. And then there's a scheduling problem. How much medication should go to each facility? Okay? So they have to have plans for doing that. Okay? They recognize that they'll have to change the plans in a real event because a real event won't match their planning assumptions. But they have to have the plan, right? You have to have a plan so that you can change the plan when the real world situation comes up. You can't start from nothing. Okay? So this model is a planning model. Okay? The key thing in this model is to increase the slack. We want the deliveries to be as early as possible. We want those two lines to be far apart horizontally. So we're trying to maximize the slack. And actually, we're going to maximize the minimum slack. Okay? We're not worried about cost here. We're worried about getting that stuff to the pods as early as possible. And the key to that is synchronizing the routing and delivery with the deliveries to the depot. So we can formulate this problem, classic kind of OR type of approach. We can formulate it as a mathematical program, and with finding the decision variables and all the constraints. And this turns out to be a version of a routing problem, although it has some extra constraints and some extra variables due to the timing and the delivery quantities, and then try to optimize that. And in this case, we're trying to optimize the slack. We're trying to make as much slack as possible. Okay? So, of course, once we formulate that problem, we have to try to solve it. Of course, this problem happens to be hard, so we've been developing a number of different approaches. With my student Adam Montjoy, who actually cannot be here today because he's in Atlanta presenting this work at a conference. He's been looking at routing and scheduling heuristics. He's also been looking at search techniques, a version of an adaptive large neighborhood search. And we'll soon be looking at column generation approaches for solving this integer program. Okay? Again, these instances of this problem may have up to 100 different sites. Okay? So that's a pretty good sized problem. Especially if we want to implement it in a tool for public health folks, we need to have simple, quick, or need a quick algorithm to solve the problem. Now,
How many parameters?
well, you have to have all the dispensing rates at all the facilities, all the travel times between the different facilities. You have to have basically the presumed scheduled deliveries to the depot. So it's a reasonable amount of data. Now, if you can get the medication to the pods, the next question is, well, how should we lay out the pods? Okay. Now, this is a problem because there's all kinds of different pods. There's pods for giving shots for smallpox. There's pods for giving out antibiotics for anthrax. There's all types of different pods. And the other thing is that every facility is different. They're going to be using schools, elementary school gyms, high school gyms, rec centers, churches, church halls, all kinds of different facilities. There's almost no two facilities are the same. So we can't really tell them, okay, here's how you should lay out a pod, because it won't fit more than one place, or maybe a small number of places. But what we can do is give them some recommendations on how to lay out the stations within the pod, because the basic unit within each of these pods is a workstation, which has a number of people doing a task, whether it's giving a shot or filling out forms or whatever the task is. So basically, based upon reviewing the literature of queue design, and based on our observations of exercises and actual clinic operations, we developed this guideline, which we call flow-through station layout. Okay, I'm not going to go into all the details because I don't have time, but you'll see the key thing is that we have multiple staff, we have a single queue, we have people waiting in queue, then they go to these little on-deck circles or staging areas, then they get served by the staff, and then they go out the other side. So that avoids a lot of the congestion that you might see. A lot of places try to set up things that look basically like the ticket counters at airports, okay? And they don't need to do it that way, but they do it that way because that's kind of what they think about, and they don't. There's a lot of congestion, especially if you're trying to process people very quickly. Now we had an application, we had an opportunity to apply this, or to kind of see an example of this in practice, when the University of Maryland Health Center decided to have a flu shot clinic last fall. So this is a map of Ritchie Coliseum. This is the front of the Coliseum that faces Route 1. And the plan was to have patients or students and staff, and faculty, come in the main doors, get some forms, fill out the forms in these bleacher areas, go to a screening station, then wait in line over here, and then go to these vaccination stations, okay, which were laid out in this kind of double line layout, which was really, as soon as I saw that, I said, that's going to be trouble. So I talked to them about that, and we were also working with them on the planning model, the staffing model. But I talked to them about that, and they said, okay, well, what would you suggest? So basically I said, well, let's move the vaccination stations. Okay? So we'll move them around into this kind of U shape. We'll have the queue basically here in the middle, while staging areas all around, and then as soon as the people get the shot, they can go through the tables to the other side, and then out the side. Okay? And they implemented that, and it worked really well. The vaccination they didn't have any problems with crowd control at vaccination. They had problems with people going in these bleachers and filling out forms. I don't know why they ever thought they could use bleachers as a queue. It's a terrible idea, and they learned that. But so it was fun working with them and seeing that work out. Now the main problem, one of the main problems, and remember I started this talk by talking about queuing. Okay, so now we come back to queuing. People are waiting. People don't like to wait in line. Crowds cause chaos. They cause congestion. They cause confusion. Okay, so the public health people are very worried about people waiting in line. They don't want lines. Okay. Well, if you look at a pod, and this is a kind of a representation or a schematic of a smallpox vaccination pod, which was one of the first ones we ever looked at. Okay, there's all these different stations, workstations that people have to go to. Okay, and you'll notice that they go through all these different stations, and not everyone goes through the same process. If they're sick or if they've been exposed to someone who's sick, or they have some medical issue, they have special treatment that's needed. So it's not a straight line, okay, queue or process. But they're worried about queuing, and they're concerned, well, where is the queuing going to be? Right? Which stations are going to have queuing? Okay? So that's what they're kind of interested in. Well, one of the first things that we did with them back in 2004 was they had this smallpox vaccination exercise at Kennedy High School in Silver Spring. And we went with some students and we collected data about all these different processes, how long it takes, what's the mean and standard deviation of all these different times, and how many people go to each process, and all that kind of fun stuff. And the first thing we did was build a simulation model, right? So I'm an industrial engineer, I know how to build discrete event simulation models, and this is what we do in our lab. So we built this simulation model. So these little tiny people down here are like the staff, and these other little tiny people here are the patients, and that's like a little bus, because they were actually transporting people to the station in buses. And then the people would go through the station, fill out some forms, go into a classroom where they'd have to watch a video about the smallpox vaccine and learn all about the dangers of the smallpox vaccine before they got it. But again, this is only an exercise, they didn't actually get the vaccine. And they'd go down the hall, go to the nurse, talk about their medical condition, maybe go see a doctor or a pharmacist, and then go get their vaccination. Okay? In the exercise, the nurse just poked them with a little stick to simulate the smallpox vaccine. And then they leave. So we built a simulation model. Tyson Cook and REU that summer did most of the work of building the simulation model, did a fabulous job, implemented all the cool animation, which I'm not going to show you today, and we took it to the public health people, we showed the public health people the animation, and they just like about fell over, okay? They just were totally impressed with the simulation animation, okay? They're like, this is great, this is exactly what happened in the clinic, which was kind of a type of validation, basic validation anyway. And we did numerical studies to validate our simulation against actual data too, because we've done complete time studies, right? So they said, we love the simulation. Now, what happens if we do this? What happens if we do that? So we did some simulation studies and said, well, what if we change things, right? What if we change the arrival rate, or what if we change the bus size, or whatever? One of the things we did was we looked at the classrooms. So we have these classrooms, and those are batch processes, and batch processes are bad, but they have to watch the video. So we said, well, what happens if we change the classroom, the number of people who watch the video at once? The classrooms are, of course, fixed. But we can say, we can have a policy. Should we watch 20 people at a time, or 30 people at a time, or 40 people at a time, essentially? And we found out that it basically doesn't make a big difference in terms of the overall time that people spend in the clinic. When the arrival rate's low, yeah, it makes a little difference, but the arrival rate, there's not much waiting anyway. But when the arrival rate gets high, there's a lot of queuing, and that classroom size doesn't make much difference. Okay? So that was just an example. But the problem is, we can't go around building simulation models for all the health departments in the United States. And the health departments in the United States don't know anything about discrete event simulation. They're not going to spend the money to buy simulation software, and they're not going to spend the time and people's effort to learn how to do this. So we realized that we can't stay with simulation. Of course, we realized there's a lot of other techniques. So basically, we turned to queuing networks. Okay. So of course, what we have is essentially a queuing network, an open queuing network. People arrive, they go to the workstation, and they leave. Fortunately, these pods are not, there's no reentrant flow, right? Basically just go straight through. And there's multiple paths, some routing and stuff. But there's nothing complicated in some sense, except for the batch processing, like that classroom. That makes things very interesting. If there weren't any batch processing, you basically just have, the typical decomposition of your queuing network, based on means and standard deviations. And you could apply your favorite GGM queuing approximation and propagate that, you'd be fine. But the batching made things interesting. So we've spent a lot of time trying to come up with better approximations that take into account the batching. Okay? And there's been some work done on that, of course, here and there, but we couldn't find anything that tied it all together, that combined the batching with the whole queuing network, you see. There's been queuing networks, and there's been batching, but we couldn't find anything that did it all together. So we had to do that. Mark Treadwell and Ali Pilavar worked on that for a long time and developed a set of approximations and implemented that in our mathematical model. So I won't go into the details, of course, here today, but basically we're looking at the clinic capacity. What's the most that people could, the highest rate at which the clinic could process patients based on the number of people and the processing times, et cetera, et cetera. Okay? What's the station utilization? You know, how busy is the station? Of course, those two things are related. And then what's the cycle time? Here, cycle time includes the waiting time, the processing time, and the movement time from one station to the next. Okay? Now, if you know anything about queuing networks, you know that the most difficult part of that equation is the innocuous little w, waiting time. Right? That's the hard thing to approximate. And that's what we spend a lot of time coming up with approximations and developing new ones to do that. Again, to take into to incorporate the batching. And of course, the total cycle time. Okay. Well, we can develop all these great mathematical models, right? And we can implement them in whatever we want to implement them. We decide to implement them in a spreadsheet, right? So we put them in a spreadsheet. These are just mathematical formulas, complicated, but just formulas. And we can let the user type, enter the numbers and change the estimate the performance measures. But again, when we first did that for the smallpox clinic that we observed in 2004. And then we did it for an anthrax medication dispensing clinic. We built another spreadsheet model. And then we realized we were back in the same hole. Oh, what are we going to do? Build simulations or build spreadsheet models for every health department in the United States, right? That's not really a good use of our time, right? It's very time consuming, right? And again, people in public health departments, although they might know spreadsheets and how to use a spreadsheet, they're not going to know the mathematical formulas and how to apply them and implement them to model their pods. So we were kind of back to like, well, now what are we going to do? Well, that's when we decided to make the clinic planning model generator. And that's really been the biggest part of our work over the last 6 years. The clinic planning model generator is a piece of software embedded in a spreadsheet, okay? Because people love spreadsheets. And it basically generates another spreadsheet. So what it does, it takes information from the user, how many people do they have, all this stuff, what stations are they going to have, et cetera, a description of their pod, basic information. It takes a template, which is kind of like a blank spreadsheet with all the formulas already in it, and then it processes all that stuff, and out on the other side comes their own, very own, personalized planning model, specifically for their pod, and even has their name on it. Right? They love it. Okay? But the key thing is they never have to get involved in this part here. There's all the work of figuring out what the equation should be. Okay? They never have to look at an equation. They just have to enter their data. And the software figures out what the equation should be. So we had to do all the work to figure out the equations, and we had to do all the work to make the software that could build the planning model. But now, all we do is give them the planning model, and they enter their numbers, and out pops a spreadsheet that they can then use. And of course, it's a spreadsheet, so they can go back and change the numbers. What if we have more staff? Or what if the probability of people needing consultation changes, or whatever? What if the processing time is smaller than what we expect, et cetera, et cetera? Okay? So here's a snapshot of the main page. Okay? So we have inputs and outputs. Number of people, how many days, how many hours, throughput. How many people per hour do we need to process in order to meet these goals? This is a simple flu vaccine, flu shot clinic. Triage, flu vaccination. How many staff do we have? How long do people spend in the clinic? How many patients are, basically inventory, right? How many people are in the clinic on average? What's the maximum capacity? How much staff do we need? How long do people wait? What's the average queue length? What's the utilization? Okay? Those queue length numbers are actually useful to them from planning purposes because not in a flu shot, it's kind of simple. But in a more complicated situation, you'd want to know where the long queue is going to be. Because then you want to have space for that, right? Or you need to set up like the little stanchions, like that, at the amusement park, right? So they know they have places for people to wait. Okay? And there's a lot of other stuff in the planning model, but I won't show that to you. We did do some comparisons of our mathematical models to simulation models. Ali Kulovar did a lot of this work. It's in his MS thesis. And in some cases, when the utilization was low, okay, it was fine, it was always good. When the utilization got high, sometimes it was good and sometimes it wasn't good. So these are examples of cases where it wasn't so good, cases where it was good. And we're still trying to figure out exactly what goes on. It has something to do with the nature of the batching and other issues. And it's not clear like why it's good or why. There's no simple policy or rule for saying when it's going to be or when it's not going to be good. But in some cases, it gives very good estimates, even at high utilization. In other cases, it doesn't. So we're still trying to figure that out. And if you know any better queuing network approximations that include batch processes, please come and talk to me, because we'd love to try them out. The clinic planning model generator was recommended by CDC for use by health departments. The state of New York recommended that all of its health departments use the model. We've had users download the model from all around the country. It's been very successful. And I go to conferences every year around multiple places talking about our work and showing people how to use this. And we continue this collaboration with Montgomery County. We're currently working on a web-based version that would get rid of the spreadsheet altogether, and that's kind of in a prototype phase right now. That's still needs more programming. We don't charge, I'm sorry, I should say also, we don't charge for the model. People can just download it for free. We don't require registration. We're trying to make it as easy as possible for people to use it. Yes?
So you can imagine that, I'm imagining that a plan for a specific clinic, for a specific
Right.
set of clinics, has a bunch of numbers they can tweak. And so then once they get their plan, the next important question they're going to have is, how do I optimize this? So have you thought about having those tools in place for helping them figure out, if this kind of staff costs me this per number of hours, then how do they start optimizing their clinic operation?
Yeah, so it is an interesting question. If I have a fixed number of staff, where's the best place to put the staff in order to optimize some waiting time? So we've decided not to address that problem because A, there's someone else already doing that, and we didn't want to compete against them. And B, there was some demand for it from the public health folks, but it wasn't like we had to have that. So we kind of just said, well, we don't really have to have it. But we did think about doing that. But there's some other people who are working on it already, so we decided not to invest our time on doing that.
I can imagine several people in this room would be.
Yeah, but that is a good question. Yes.
So this is specific to, or how specific is your model to the kind of health-oriented emergency that, for example, if there's a snow emergency, right? I mean, we have something similar.
So the clinic planning model generator is specific to public health emergency type of operations because it includes data that we've collected from time studies of exercises in actual clinics over the years. The queuing network model is very general, of course, and can be applied to any type of network situation. I'm sorry, yes. Yeah, we're using the traditional types of GGM approximations based on the mean and standard deviation of the processing times.
Those are usually steady-state approximations.
Yes.
So if I go back to, for example, you had that is happening,
Right.
but people come typically an hour before the gates open. So how does this calculate?
Okay, so the issue of steady state is a very important question. Partly to answer that question, I will say that we have looked at the case of what we call mass arrivals, which is the case where a bunch of people are standing in line before you even open the doors. And Adam Montjoy looked at this problem back when he was in REU a few years ago. Okay, in that case, with the large number of people waiting at the beginning, we just used kind of a deterministic fluid flow model. In terms of the validity of using the steady state model, that's something we go back and forth with the public health people about. What we try to do is to educate them about the assumptions we're making, and to say, well, look, this is in the steady state. Okay, this won't apply when you first open the doors. Okay, and if the arrival rate is going way up and way down, then maybe you're never in steady state. Okay, the capacity numbers are okay, of course, but the queuing numbers would be off if you're not in steady state. So we just have to educate them and work with them on that. Obviously, if we had a good idea of the actual arrival rate pattern, we could try to build better models or go back to simulation or something, but that just requires more data, and we haven't been able to do that yet. But it's a good point. Yeah, that's steady state issues that we can talk about. Okay. Now, the last thing I wanted to mention is we we looked at like the specific processes involved. Now we can't really go tell nurses how to do their vaccines better. Like they're the nurses, they know how to do it, right? But there's other parts of the process that are basically data gathering. And it's really amazing. You go to these things and you have to fill out all this paperwork, right? You have to fill out these forms in triplicate or whatever, right? And just to get real basic information, which is really basically, are you allergic to this medication that we're about to give you or not, right? They don't want to give you medication if you're allergic to it, right? Essentially, that's what we're trying to say. So we looked at the medical screening problem. So this is I know this is kind of small, but the point of this is a form that the people in the National Capital Region have developed for medical screening for doxy and cipro, which are the two most commonly used antibiotics for anthrax, or would be used for anthrax. And there's a number of questions on here about whether or not you're pregnant, or whether or not you're under 8 years old, okay, and whether or not you're allergic to doxy, and whether or not you're allergic to cipro, essentially, and anything related to those antibiotics. And based on your answers to that, the little logic up here is basically says, okay, should you get doxy, or should you get cipro, or should you go talk to your doctor, okay, about what you should do, okay? Well, in a mass dispensing situation, you're going to have people filling out these forms, and then you have to have a nurse or someone look at all the answers and say, okay, person A is no, no, yes. Okay, they get, doxy. Person B is no, yes, no, they get cipro, or whatever, okay? So there's a lot of chance for confusion, plus it just takes a long time, okay? So we developed a little program that we call eMedCheck, and we implemented that on a PDA under the Palm OS, and it basically does that automatically. You ask the question, how many people in your family, household, or who's pregnant or under 8, who's allergic to doxy, who's allergic to cipro, and then it goes through and quickly determines who should get doxy, who should get cipro, and who should go see the doctor. And it tells and you can tell them that, and it records the information for later data collection. Okay? Well, we developed that for doxy and cipro, and then later we had some collaborators in Tarrant County, Texas, which is near Dallas-Fort Worth, who wanted to use it for hepatitis A screening. So we modified the software, made a version for hepatitis A, because of course the questions are all different, and then gave it to them, and they used it in their hepatitis A clinic. And when they tested it, or when they used it, they realized that we could do just as good a job as the paper form, a lot faster, and with no chance of mistakes, because it's just a computer algorithm. As long as you verify the computer algorithm, which is not so hard, it works. Of course, now this is on Palm OS. Of course, now people are asking, well, can I get it on my BlackBerry, or can I get it on my iPhone? And so now we're beginning to look at that. And so if you're interested in programming BlackBerries or iPhones for this kind of thing, let me know.
Why wouldn't you do it as a web-based program? Then you'd be OS independent.
Right. Yeah. I mean, that's what I keep telling them. Like, why don't they just fill this out online before they even come? Right.
Yeah.
But you have to have something in place so that people can forget to do that, or never get the message or whatever.
I mean, every single device now has some kind of web browser. That's a standard.
Right. So you can just have a web service, right? Yeah. That's a great idea. You want to do that?
It's making devices for
The fact that they have to do something while waiting, is there an advantage to that as well?
Well, no, I mean, from a queue design, yes, right? If you're going to have a queue, you might as well keep people busy.
Which is the buffer, right? Which is smoother the input.
But if we get rid of the queue, that's fast.
But then it would have to be a reservation time.
That's something they talk about in the mass dispensing case. They talk about how we're going to smooth the arrival rate. And they talk about, by street number, or by neighborhood. I mean, there's different schemes, but they haven't really decided to do that. I mean, basically people are just going to show up early. That's what's going to happen. So, but the thing is, assuming they have enough medication, there's no need to show up early. They're going to have enough medication. Just wait a few hours and show up later after the crowd is gone. In the case at Maryland, the one in Maryland, they had 100 people waiting outside the door in the rain, to get a flu shot. And by an hour and a half later, you could just walk right on in and get a shot in 6 minutes. It was crazy. Keep working.
Do your models take that into consideration?
No, that's an interesting. No, that's a good question. I should probably propose it. We've written a lot of papers on this over the last few years in different journals and conferences, and it's been a lot of fun doing that as well, and getting the chance to present that work. A few final thoughts. Basically, one of the things I try to stress with the public health people is that these planning models are designed and are meant to create a conversation. And this little cartoon here is kind of exemplifies that. You see, here's the person working on the computer, they got the model, right? But then there's all these other people standing around, and they're all supposed to be talking about their plans. Planning is a process. You don't go to the computer, type in your numbers, and the computer doesn't spit out the answer and says, here's what you should do. Because this problem is too complex. Okay? But the computer models, or the models that we've developed and implemented, are meant to help that planning process. Well, what if we do this? What if we have 5 pods? What if we have 50 pods? What if we do this plan? What if we do that plan? What if we can get more vehicles? All these what if things, which is all important part of this planning process. So we spend a lot of time working on the mathematical models and all this fun stuff, but I try to stress to the public health folks that we're not giving you the answer. We're trying to help you make decisions, right? It's decision support. Planning, it's for planning, it's to improve planning. Okay? And there's a lot more opportunities to apply operations research and other techniques to these problems. We're going to be, in the future, we're going to be looking, in addition to things I mentioned before, we're going to be looking at alternate care systems. Alternate care systems have to be put in place when you have some kind of emergency and there's too many sick people to go to the hospital. The hospitals are overwhelmed. So then you have a question of what's the best allocation of resources. Should we open this type of clinic, or should we open this type of facility? There's a lot of interesting decisions that have to be made. And we want to help them optimize the allocation of their resources. I'm currently developing a proposal with the Gemstone team to look at some of these processes of detection and investigation, kind of do the field work of working with health departments to figure out how do they actually do this and how can it be made better. We're going to be looking at stochastic models. You asked about deterministic. The stochastic models, especially in the medication distribution, maybe using some simulation and optimization techniques to come up with better plans, more robust plans. We're going to be looking at traffic models, because the pod planning, we assume that people just walk in the door, right? But people don't walk in the door. They have to drive there. And then you have parking lot issues and road network congestion issues. So look at that. Maybe we can expand our pod planning models to incorporate traffic and parking issues as well, and other things. In general, this research, I hope I've conveyed, or this research that we've been doing, is really an ideal research project. If you think about it in the big picture. We're starting with real-world problems. We're developing new techniques, new models. We're testing them on real-world data. We're implementing them. We're getting people to use them. We're writing papers. We're developing new ideas, writing proposals. We're training graduate students. And we're doing the whole thing. And it's a great, in my mind, it's a great experience, to be in the middle of all that. And I'm kind of the public face of it, because I'm the faculty PI, right? And I'm in the middle of all these different things that we're doing. And it's just been a wonderful opportunity over the last 6 or so years. And as a faculty member here in the ISR, I want to invite my colleagues to join me in this effort, because there's a lot more interesting stuff that we can do. And the public health people, they love this stuff. Whether it's something simple or something sophisticated, if we can make it help them solve their problems, they will use it. Okay? We've worked really hard to develop these relationships, and it's not just with Montgomery County, it's with people all around the country. And we have a really great opportunity here. Of course, like I said before, I'm the face, but I couldn't do it by myself. The funding that we've had originates with the Centers for Disease Control. It goes through the National Association of County and State Health Officers. which sponsors this advanced practice program, advanced practice center program. Montgomery County had one of the original advanced practice centers. They've got renewed funding to continue for another 5 years or so. So we look forward to more collaborations with them. The 4 ladies listed here, Kay, Rachel, Carol, and Kathy, have just been wonderful collaborators. From the very beginning, they've really been open to using mathematical models and advanced information technology to come up with better plans. And it's just an ideal collaboration. I can't thank them enough for their support and their encouragement over the years. And of course, it's not just me, it's all the students. And there's been a lot of students over the years, undergraduates, REU students, graduate students, some of whom don't even work for me. And they come out and help out with the time studies and analyze the data. And so I want to be sure to thank all of them and be sure to give them the credit because they're the ones doing the hard work. I just get to get up here and talk about it. So thank you very much.
Thank you for such an inspiring talk. Questions?
Actually, before I came here, I was hoping you were not assuming that when your model is adopted in an emergency situation, there's going to be an instant frozen of the human emotions that distracts the healthcare workers, especially the incidents in Haiti and in Chile. So I was kind of thinking, how have you incorporated or integrated this kind of mayhem or chaos into the mathematical model to make sure that it doesn't get stuck in the middle of an emergency relief?
So I'm not sure I'm trying to understand your question, but so what you're saying is that in an actual public health emergency, there's a lot of chaos, a lot of mayhem,
right?
And you're asking about whether or not we can model that?
Yeah, I know. Assuming that chaos and mayhem is frozen in time,
Yeah.
and the people are just standing on a space. How is your model how is it efficient to serve them even when the chaos is frozen and just the people are being attended to?
Right.
How is it more efficient? And after that, include the factor of the chaos and see how efficient it will be.
Well, so when there's chaos, when there's mayhem, it's a very dynamic and fluid situation, right?
Right.
So this is what I was trying to stress earlier about you have to have a plan. You have to have a plan of what you're going to do. But then when the situation occurs, and the situation is dynamic and fluid and all that stuff, then they have to, that's where the people on the ground, the people running those facilities have to be adaptive and react to that. Within the context of the plan, if the plan is still valid. But if the plan becomes invalid because the situation's changed, well then they've got to throw out the plans and make a new plan. Okay? So, that's a very difficult situation. And our models aren't a silver bullet for that. But it's a very important point that you bring up, and I appreciate that question. Was there a question up here?
Is there a way to adaptively select the field model so that it can improve performance of that?
I don't know. We haven't looked at that. We basically used different approximations, and based on the characteristics of the pod, instantiated those approximations to estimate the performance. We haven't tried to adaptively do that. I don't know how to think about that.
Because in this model, you have fixed the model of the cube, and when you assume certain parameters for that,
Yes.
but it may not actually reflect the known situation.
Right.
As you said in the beginning, the bank doesn't work and everything goes bad, as you have.
Yeah.
But in the case of actual data,
Right.
is there a way to adaptively change?
Yeah, okay. Well, yeah, because if you have the model and the situation has changed, and you can update the numbers in the model. That's one of the reasons why we use the spreadsheet implementation. Because it makes it very easy to update the numbers. Okay, but again, there's an address. If it's changing too much or if it's not steady state, then the model's not a very good model. It's not going to be very helpful. Back here it is.
Yeah, So if your models and your program were to be utilized, for instance, by another country with such a different population density, like for instance China or such, would there need to be sort of changes made to the modeling software to account for such a different starting condition, or will it still probably fit it just the same, similar as the United States?
The basic pod model wouldn't be affected by that. The processing time distributions are adjustable. So if for whatever reason, I mean, it wouldn't matter if it's China or or Nevada. It wouldn't really matter. Whatever the local experts decide is the most appropriate distribution to use. I mean, the model can accommodate that. So it's very, I mean, it's generic in that sense. Yes.
I'm curious about the distribution aspects of getting, let's say, an anthrax vaccine or a flu vaccine to these various places. I'm wondering why I'm curious as to why the public health people are really tackling that problem when you have organizations like FedEx and UPS that have these very sophisticated delivery models. Rather than sending the medication to, kind of this hub and spoke model, FedEx and UPS already have these very, very sophisticated delivery platforms. Yeah. It seems like the public, in my mind anyways, it seems like the public health people their time would be better spent, with the stuff that you were talking about in the last part of the talk. How do you see the work that you're doing, that you were talking about in the first part of the talk? Yeah. How do you see that helping them?
Well, I mean, the answer is that some of the larger public health departments have done exactly what you suggested. They basically contracted out the distribution operations to parties like FedEx or whoever who have that experience. And the federal government uses these kind of commercial carriers to do the work. Okay, from a planning point of view, we're trying to help the health departments understand how this would affect the operation of their pods, and no matter who does the actual driving, we're trying to understand what the impact is. We have talked with firms that do commercial vehicle routing software and work with these carriers to try to integrate our distribution model with their software. That's still in progress. That's a good point. Over. I think Mark and then Bill.
I was wondering if places like the UN would be interested in this work. If you think about what happened in Haiti, right? I mean, the UN was right there, and you think, well, they'd be in the business of setting up these pods even before an earthquake comes.
Right. And there are the relief agencies and like American Red Cross and folks. I mean, the larger ones, they have their own in-house expertise for doing this. I met with some of the folks at American Red Cross, talked to them about this, and they kind of have their own staff who do this for a living. The CDC, they have a big modeling group as well. I don't know about the UN. And there are other researchers looking specifically at the area of humanitarian logistics. The firms that do this for a living, the commercial people, they get together and support relief efforts, voluntarily as well. So it's not. I mean, there's a lot of people working on this, but yeah, there's a lot of potential applications.
But that assumes that you have the viable infrastructure.
Yes.
In your case,
right.
Infrastructure is going in shambles. So
right. So that makes that's a big, much more difficult situation. That's Bill, you have a question?
Actually, there's a comment that FedEx has a very different problem from the public health services. FedEx only has to deliver, and they want to keep their costs down, and they have to meet some kind of a deadline. But the public health service problem is much more severe. You have to deliver on time to all of the appropriate places because you simply don't want to have people queued up and no dedication.
Right, that's the point. And what I didn't mention in my talk was that there's actually two different distribution problems. One is the problem I mentioned, which is the initial distribution to get all the pods up and running. But if this campaign is going to last a long time, then you have this resupply problem. And you have to keep everybody resupplied without running out. So it is a slightly different problem. And the model that we've been studying is unlike any other existing models because of that reason. Yes, and then we'll go back.
So one, I slightly disagree because FedEx does have they have to deliver it to certain people every 6 hours, the same package over and over. I've been with employers where that's the case. So that's not quite a true statement. But my other question was, in cases like Haiti, and this was already kind of brought up, do your models incorporate what happens when there's an emergency at, let's say, one of your pod locations where it has to shut down? Have you talked about incorporating these kind of chaotic events really disturbing this model?
No, you see, because our model, we're not trying to predict what would happen in all these dynamic situations. We're trying to provide the models to help people react to them and figure out what to do once it does happen, you see. So like, for instance, if you have a plan that called for a certain number of pods, and then for some reason you couldn't open some of those pods because of whatever the problem, then you'd have to replan. And then you could use the models to figure out what's the impact of that on your plan. But we're not trying to account for all the possible disruptions that could occur, you see. It's kind of a different issue. Yes, sir?
In your talk, you actually mentioned that people are crazy, and I do appreciate that statement very well because I agree. But the first question is, why do you think people are crazy in terms of this situation? And then the second question is, do you think it's possible to have people in a certain square mile radius kind of have a sensors which include all their names in a particular model, so when the situation occurs, you already know their names, you already know who lives there. So when the nurse practitioners get there, like, let's take 1/10 of Haiti's problem happening here in Montgomery County or PG. You have all their names in there. How are you, do you think that would be something possible to do? Because it's not.
So you're talking about like having a pre-registration.
Pre-registration with all the names they put in the area. So when something occurs, you already know who is in the system. And
we've talked with them a little bit about stuff like that. And one of the things that comes up that would mitigate the benefit of that kind of system is that they'll basically take anybody who walks in the door. And it doesn't matter if they live in that area or they come from the next county or the next state or they're just visiting relatives. So they haven't really talked about situations in which they would give medication only to specific people, that live or residents in a certain area. They're the public health people are very much, we want to help, and we will give medication to anyone who shows up. But that pre-registration could be useful in some situations, but we haven't addressed it.
That's different. What if you have a color, like a blue color and a red color? The blue color takes the name of people who live there permanently.
Yeah.
The red color people who come in and go. So even if those give anybody medication, I think that should be a different constant in the equation, plus a constant that is registering names.
Right.
Just names.
Yeah, I agree. That would lower the time required and maybe the staffing required.
Right.
But we haven't worked on that, and they haven't really. I haven't seen any counties health departments who are really planning to do that. But it's a good idea.
Well, let's thank Jeffrey. He's going to stick around for